This is Dr. Michael Wong, and I'm reporting from the 2013 ASCO here in Chicago. We've just come back from the PD1 sessions, and there's some tremendously interesting news to hear about. First of all, it looks like this PD1 pathway, which is a pathway that the immune system uses or cancer uses to stop the immune system from working, inhibition of that pathway is going to be very, very useful. We've heard several talks today, and they consistently show a response rate in the 20% range, if not more. And if you define response as shrinkage of tumor and also stability, then the response rates can be sometimes double that. Now, the flip side of efficacy is toxicity, but it looks like it's really well tolerated. The things that we really worried about, which is colitis, inflammation of the colon, pneumonitis, which is inflammation of the lungs, both of which can be fatal, are not seen here. So that's something which was extremely heartening to see. Now there's some other news which is really important as well. It seems that those individuals who failed ipilimumab, which is currently one of the FDA-approved standards of care in melanoma, that if you fail that therapy, that the inhibition of PD1 seems to be also useful, and vice versa. So it looks like these two therapies have what we call non-overlapping resistance. In other words, if you fail one, you can use the other, and so the question comes, what's the best sequence? We don't know that. Jed Walchuk from the Memorial Sloan Kettering Cancer Institute in New York City showed something extremely interesting. They did a study where they looked at combining both the PD1 inhibitor and ipilimumab, and they had to do it carefully because using both may be toxic, because it's an extremely powerful way of unleashing the immune system. And what Jed showed was that the response rates are in the 40s, and if you use what we call the clinical response rate, which is shrinkage of tumor or even stability, that number can be even in the 60% range. Now, this was a bit more toxic. They did see toxicities related to this, but in his own words, these were things that we had seen before with ipilimumab or the anti-PD1 antibodies separately. And these include inflammation of the lungs and colitis, and that was seen. The striking thing as well is that they saw responses which were not seen before, the type of responses where you almost have to see it in chemotherapy. He describes rapid shrinkage of tumors that were deep and profound, 80% shrinkage within the first 12 weeks, which is when we look at the first CT scan. So this is strikingly good news. I think Walter Erba, who summarized this talk this morning, was extremely helpful. He mentioned the tail on the curve. What is that? It is a survival curve. It means that these people have lived a very long time, if not cured. And the reality is that our hope is to get more and more of these people basically with long-term durable responses. And it seems that we're in the right direction. So PD1 is going to be an extremely important pathway. How we sequence it, how we treat it, how we use these drugs, still unknown. One of the questions raised was, do we actually need to do phase 3 trials now that you have this data? The answer is unequivocally yes. It's early information. Jed Walchuk's study with this wonderful response rate we've seen only has a 13-month follow-up. That's very short. It's a blink of an eye in oncology. It's also from a single institution, and these patients are highly selected. So we need to know whether it's for everyone, and if not, then who exactly it's for. So there's still work to be done. It's incredibly promising. I think this is going to be a pathway that's going to be increasingly interesting and important to us.